RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I am your host, Amanda Mixon, president of RhAPP, and today we're kicking off a very special edition. This will be our EULAR ILD RhAPP Up series. Throughout this three-part series, we will break down some of the most important and practice-changing data coming out of the 2026 EULAR Congress, with a focus on interstitial lung disease. For today's episode, I'm excited to be joined by Jessica Glennie, a pulmonary APP and expert faculty member of APAP, who brings extensive experience with ILD management. Jessica, before we jump into the data, would you mind introducing yourself to our listeners and sharing a little bit about your background?
Yeah, absolutely. It's lovely to be here with you, Amanda. I always love doing these with you. I'm Jessica Glennie. I'm a nurse practitioner at the Cleveland Clinic in Cleveland, Ohio. I've worked specifically with the interstitial lung disease group there for about 11 years. So it's really a growing space. It's a lot of fun. And I get to partner with RhAPP and with my rheumatology colleagues. So it's always a fun time.
Well, it definitely benefits us, and we're so thankful to have you here. So we have a lot to cover, so let's just go ahead and jump into part one. So I'm going to start us out with talking about abstract AB0288, Economic Burden and Healthcare Resource Utilization in Patients with Connective Tissue Disease, Associated Interstitial Lung Disease, a Systemic Literature Review. So the overview of this study, this was a systematic literature review evaluating the economic burden and healthcare resource utilization associated with connective tissue disease-associated ILD across multiple autoimmune diseases, including systemic sclerosis, rheumatoid arthritis, Sjogren's, lupus, inflammatory myopathies, and mixed connective tissue disease. The background, CTD-ILD is a major contributor to morbidity and mortality in autoimmune rheumatic diseases, but its financial and healthcare system impact has not been well characterized. Understanding the economic burden of CTD-ILD is important for healthcare planning, resource allocation, and demonstrating the need for earlier diagnosis and intervention. So this study aimed to summarize available evidence regarding the healthcare costs, hospitalizations, outpatient utilization, and productivity loss associated with CTD-ILD. The methods: investigators performed a systematic literature review of studies published from 2010 onward, evaluating costs, healthcare resource utilization, productivity loss, and economic outcomes in CTD-ILD populations. Studies from several major countries, including the U.S., Canada, the United Kingdom, France, Germany, Spain, Japan, and China were included. Data extraction focused on direct healthcare costs, hospitalizations, outpatient visits, pharmacy utilization, and productivity-related outcomes. So the results: 15 studies met inclusion criteria for detailed analysis. Across CTD-ILD populations, investigators found consistently high healthcare utilization and economic burden. Patients with systemic sclerosis-associated ILD demonstrated particularly high healthcare costs, with one U.S. reporting annual direct healthcare costs exceeding $37,000 per patient, and another reporting $191,000 over 5 years. Frequent hospitalizations, outpatient visits, imaging, ICU admissions, and pharmacy costs were major drivers of expense across disease states. Productivity loss was also substantial, with studies demonstrating significant absenteeism and reduced work productivity among affected patients. Data availability was strongest for systemic sclerosis-associated ILD and rheumatoid arthritis-associated ILD, while evidence remained limited for lupus-associated ILD and mixed connective tissue disease-associated ILD. The authors' conclusions were that CTD-ILD is associated with substantial healthcare utilization and significant economic burden across multiple autoimmune diseases. Frequent hospitalizations, ongoing outpatient management, and medication related costs contribute heavily to this burden. The authors concluded that additional research is needed to better define the economic impact of CTD-ILD and to support strategies aimed at improving disease management and reducing long-term healthcare costs. So let's get into what this actually means for our patients. Jessica, what are your first thoughts on this?
Yeah, well, I guess my first thought is what an interesting paper because we don't usually think about these types of things, the economic costs to our patients. Um, and my second thought is I'm not particularly surprised. I mean, these are patients that have oftentimes multi-organ involvement. They do have a lot of very expensive specialty medications that they're taking. Um, Patients with interstitial lung disease have pretty frequent outpatient visits and hospitalizations for exacerbations and respiratory events and things like that are quite common. So my thought was, boy, this doesn't surprise me too much. It was interesting to see that number for the US, and it would be really interesting to see if that's different in those other countries. If, kind of different ways of providing healthcare and healthcare allocation and insurance and things like that makes a difference. Um, but this is something that our patients are worried about and thinking about the cost to them. So I'll start with the cost to the patient. Not being able to do what they love anymore, maybe not being able to work. So the emotional impact and the impact on their family, not being worried about, how am I going to afford this medication or not being able to get on a medication because of insurance or health cost issues. So it really is something that our patients are dealing with quite frequently as to how to manage that part. Obviously some higher level policy changes than what we can offer as clinicians, but at least kind of keeping that costs in mind for our patients and really finding these diseases early so that we can prevent them from having the severe disease and all these costs down the line is so important. So those are kind of some of my thoughts right off the bat. What about you, Amanda?
I had the exact same thought. I wasn't shocked when I,
Yeah.
read that. Particularly with our scleroderma patients, the diffuse scleroderma patients. I mean, those people tend to get very sick and require a lot of resources. And to your point, I mean, the fear of not being able to afford your therapy or you can't work and you lose your insurance. And then what does that look like in terms of the cost to the system? If someone doesn't have insurance, but they still get really sick, of course, they're still seen and cared for. And so I think it's multifaceted, but I think exactly what you said. We need earlier detection. We need earlier treatment strategies so that we can prevent these patients from actually potentially, losing their jobs, the cost to the system, preventing ICU hospitalizations, which we know are astronomical in cost. And so, again, same. Wasn't shocked by the numbers,
Yeah.
but really thinking about what we can do to try to help that because we know anything that you find earlier is more treatable, and then in the long run, costs the system, costs the patient, costs the health insurance, costs the hospital less.
Yeah.
And I really just think personally, we need to change from a reaction in medicine to a prevention in medicine. And I think that that's a much larger discussion. But I would love to see in our lifetime really focusing more on prevention to where we can catch these things early as possible to help prevent some of these complications.
Yeah. And then I was thinking a little bit about, this made me think about a patient that I had who was going through she had, antisynthetase, dermatomyositis associated ILD with pretty rapid progression, young girl, on, like, kind of max therapy and going through lung transplant evaluation, and she had to keep working even though she was so sick she could barely work. but she had to keep working for her insurance because she was too old to be on her parents' insurance, and she wasn't married and couldn't be on like a spouse's insurance. And so, I mean, this poor girl, it kind of speaks to an even larger problem too that we're not going to solve today, but you know, have to kind of keep in mind, need for policy changes to make things more affordable for patients, and cut costs, or for healthcare in general. But yeah, very interesting study.
Very interesting. And really, I think we need more studies like this because I
Yeah,
think the more studies that are out there, perhaps more change can happen,
yeah.
from a global perspective.
Right. I did read a study about all the different antifibrotics, and they looked at the cost versus benefit of them based, like, financially, like, how, because 'cause they're very costly medications, and are they benefiting our patients enough to make it, like, you don't wanna think about that, like, a patient's life being like a cost versus benefit, but that's what it was looking at, is it really the cost of these medications to us and our healthcare system, is it, like, kinda worth it? And they kind of determined it wasn't based on, like, the extreme costs of these medications and things like that. But anyway, it was interesting. So there are some studies out there, about these types of things. So, um, yeah, very interesting.
Again, more data needed as we
Yeah,
as we move
for
forward.
sure, for sure. But yeah, I think prevention and early, identification is key for us from a clinician standpoint.
Absolutely.
Yeah.
Okay, do you
Okay.
have an abstract
Yeah.
for us?
Yep. We'll go on to our next one. So the second abstract we're going to talk about is a phase 3 double-blind randomized placebo-controlled trial evaluating the safety and efficacy of oral nerandomilast treatment on halting disease progression in systemic sclerosis. So, overview of this study. This abstract outlines the design of the phase 3 veranda, scleroderma trial evaluating nerandomilast, which is an investigational oral preferential phosphodiesterase 4B inhibitor in patients with systemic sclerosis. The study aims to determine whether nerandomilast can slow overall disease progression in a multisystem disease with limited treatment options. So background and purpose is systemic sclerosis is a complex autoimmune disease characterized by immune dysregulation, fibrosis, and vasculopathy affecting multiple organs, including the skin and the lungs. Currently, there are no approved therapies that comprehensively target all major pathways driving disease progression. Nerandomilast has demonstrated immunomodulatory, antifibrotic, and vasculoprotective effects in preclinical models and has already shown benefit in fibrotic lung diseases, including progressive pulmonary fibrosis. So, the purpose of the Veranda SSC trial is to investigate whether nerandomilast can meaningfully impact disease progression in systemic sclerosis. Really interesting. So, not just looking at fibrosis, but looking at all different parts of scleroderma, all these different pathways that are affected. Veranda SSC is a global randomized double-blind placebo-controlled phase 3 study expected to enroll approximately 448 patients with either diffuse or limited cutaneous systemic sclerosis across 45 countries. Participants will receive nerandomilast 18 milligrams twice daily or placebo in addition to their standard of care for at least 52 weeks. Eligible patients must have relatively early disease with evidence of active systemic sclerosis. The primary endpoint is a composite measure evaluating clinically meaningful disease progression, including decline in lung function, worsening in skin fibrosis, systemic sclerosis related complications, or death. Results of this study. Um, uh, as this is a trial design abstract, efficacy and safety outcomes aren't yet available, but the study will assess the impact of nerandomilast on disease progression, lung function decline, skin involvement, organ manifestations, patient-reported outcomes, and overall safety and tolerability. The author's conclusion, the Veranda SSC trial represents a novel phase 3 study designed to evaluate whether nerandomilast can slow disease progression in systemic sclerosis by targeting multiple underlying pathogenic mechanisms. Investigators believe this approach may address a major unmet need in systemic sclerosis, where few broadly disease-modifying therapies currently exist. Okay, so nerandomilast. So we've had some, experience with this drug already with progressive pulmonary fibrosis. Have you had some experience with this drug yet on your scleroderma patients? And what do you think about this study, Amanda?
Oh my gosh. I am so excited for this.
Yeah.
I hope that it works on multiple domains within scleroderma, right? Because, every time I diagnose a diffuse scleroderma, or limited scleroderma for that matter, patients will say, like, is there a medicine that I can take that will truly treat this disease as whole? We have so many therapies for, rheumatoid arthritis and psoriatic arthritis and lupus but scleroderma, unfortunately, we just don't, and to have a potential therapy that could target different domains, particularly the skin manifestations, of course, the lung manifestations, but all of these other things. I mean, if this works, I mean, it could be a game changer for our scleroderma patients.
Yeah, yeah. I think we already have evidence based on some of the abstracts that we're going to talk about later about the improvement in decrease and decline of forced vital capacity. So, helping patients to decrease their lung function decline and decrease fibrosis, slow fibrosis progression. But these other two are still iffy. The other things, these PDE4 inhibitors do have some vascular effects, and sometimes we actually are concerned with this group of medications about vasculitis. And then we have a couple, apremilast and roflumilast. Roflumilast is for COPD. Apremilast is for a couple of your diseases, Behçet's and psoriatic arthritis. And so it has anti-inflammatory properties for those disease states. So wouldn't that be amazing if we saw that with nerandomilast? And I think in the FIBRONEER trial, they did see what they called a nerandomilast bump, which means that their FVC, their forced vital capacity, actually improved a little bit. And they thought that was related to maybe some of the anti-inflammatory or like immunomodulatory properties of this drug. So yeah, very interesting to see if we can have something that we can maybe even, if this hit all those categories, this might go straight up the list to, right when we start mycophenolate or even before mycophenolate for scleroderma patients. Would this be, a primary drug that we utilize?
Absolutely. Like, again, it would potentially change, our, to your point, like how we treat these patients right from the get-go.
Yeah.
Because that's obviously such a concern. I mean, of course, these patients do not want to get interstitial lung disease. They don't want to end up needing lung transplants, etc. But the skin manifestations are just as scary to people. They feel like they're kind of turning into the Tin Man, and they lose the ability to really use their fingers, and then the ulcerations to their fingertips. I mean, I've had many patients lose fingers. I mean, and so to potentially have a target that could slow that progression more so than what we currently have, I think would be so exciting.
Yeah. Yeah, absolutely. So yeah, this will be a good one to see. And I feel pretty confident we'll see some impact on the lung function based on previous ones. But yeah, I think it'll be really, really interesting to see where this one goes.
Well, thank you so much. I hope everyone enjoyed this. That wraps up part 1 of our EULAR ILD wrap up. Be sure to join us for part 2, where we're going to continue breaking down the most relevant updates from EULAR 2026. See you next time.